Good morning or good afternoon, everyone, depending on where you're located. Thank you for joining today's Community of Practice session. My name is Danny Hansler, and I'll be your host and tech producer for today's session. We're excited to bring you this important discussion, as you can see on the presentation,
Oh my God.
what's new at the New Hampshire Harm Reduction Coalition. Before we begin, though, with this session, we just want to go over a few reminders. Please remember today's session is being recorded. The recording will be shared with the participants, so feel free to revisit the material later. But that being said, be mindful of your microphone, please, to ensure a smooth experience and recording. Please keep yourself muted unless you are participating in the program. You'll find the mute button at the bottom left of your screen. If you cannot hear us, please make sure you have the right right speaker selected, and also the right microphone if you're going to participate in the program. Also, please, we encourage everyone to use the Zoom engagement tools with the reactions. You're going to find these at the bottom. Right in the center, you have the reactions buttons. You can react to what's being presented. And also the chat feature, if you want to post some questions, we'll be monitoring those. With that being said, I want to hand it over to Dan Andrews, who's going to cover the objectives that get our discussion going. Dan.
Thank you, Danny. Well, welcome to this session, which I am particularly excited about. To welcome Liz into this space. Today, we're going to learn more about the educational services offered by the New Hampshire Harm Reduction Coalition, and particularly those that pertain to our hospitals and healthcare system, and as importantly, understand how to access those services for staff and for patients. And I'm ready for the next slide. I think I do an introduction now. I am very pleased to welcome Liz Beaule. Liz has been a personal friend for over 3 years. We spent many Sunday afternoons and Wednesday evenings at the Queen City and Concord exchanges, and I know her to be a person of passion, high competence, and incredible commitment to this work. I was so pleased by her appointment as Director of Education and Technical Assistance, where she is continuing to drive programs forward. Liz brings a tremendous amount of lived and living experience in drug use and in recovery. In her current role, she works to teach individuals and organizations comprehensive evidence-based drug education. She spent years working closely with participants to identify their wants and needs around community drug education and training. Liz works hard to maintain an engaging, factual, and respectful curriculum that holds participant experience and knowledge at the heart of it. She has a great deal of experience in direct service and working with clients that are experiencing homelessness and co-occurring disorders. Prior to work at NHHRC, she worked in substance use treatment, peer support, and activism. Liz's presentation will be powerful in showcasing how harm reduction programs are not only about helping individuals, but also about improving the public health of the entire state. She'll present the Harm Reduction Coalition's activities and services offered throughout the state. She will share how the coalition has developed many outreach programs and initiatives that have a positive impact on New Hampshire's public health. She'll discuss NHHRC's core values of ending the overdose epidemic, reducing disease transmission and rates of infection, and meeting people where they are at while navigating acceptance among mainstream services. It's my pleasure to welcome my friend Liz to this community practice meeting.
Thank you so much, Dan. Hold back tears a little bit. Dan always gives me the best intros. I am so excited to be here with everybody today, and hopefully we all walk away with learning something new. So without further ado, if you would like to start the slides. Perfect. So what is new at New Hampshire Harm Reduction Coalition? Well, other than constant advocacy and lots of hard work, there are lots of new programs we're offering, and myself, there's lots of new trainings we're offering. So real quick, we're going to go through what is harm reduction, and then what's happening in our programs across the state. Next slide. So, of course, what is harm reduction? It can be a litany of many things. So harm reduction is as simple as the sunscreen we put on before we go to the beach or the seatbelts we put on before we drive a car. But when we're specifically talking about harm reduction, we're talking about trying to reduce the negative consequences that are associated with drug use. Next slide, please. So harm reduction is a set of practical strategies, and they are aimed at reducing negative consequences associated with drug use. I like to add in here that we're also talking about sex work and social economic standings for folks as well. Harm reduction isn't just that drug use piece, but it encompasses the whole person. It's a whole person-centered approach. It's also a social justice movement because we work very hard to respect the rights of people who use drugs and put their experiences and information at the core of everything we do. We accept that drug use is a part of our world, and we work to minimize the harm rather than ignore or condemn it. I really like to always say that, unfortunately, the war on drugs is over and drugs won, and now we need to figure out how to heal people. This is not a war anymore. This is the sewing up of wounds for people and the connection to services. We understand that drug use is complex with a continuum of behaviors, and some ways of using drugs are safer than others. Of course, if you were somebody who had an Adderall prescription and you used that, that would be safer than buying pressed Adderall off of the street. But overall, harm reduction is a non-judgmental approach to empower drug users to share info and support each other. Participants and folks that use drugs are their best advocates. They are the best people to share information, to share safety information, to share how supplies in drugs change. So we focus very heavily on empowering them to share that info with each other in their communities. Next slide, please. So at the core of what we do, harm reduction is a set of evidence-based practices. Everything we do is backed by 20 years of evidence on how well these practices and strategies help to protect people who use drugs and continue their health and wellness, their healing, all of the things that we hope happens when somebody is in that kind of suffering and isolation that can happen during substance use. We are grounded in principles of human rights and public health. Our biggest goal is to improve the public health. So that is working with hospitals, community partners, everything in between so that we can make the biggest impact for folks that use drugs. We also incorporate a wide array of approaches. Harm reduction is truly the catch-all path for folks who are looking to get into recovery or folks who are just looking to be a little bit healthier. That includes abstinence. It's designated to meet people where they're at. And when we say that, what we mean is literally meeting them where they are. We have outreach vans that go to where people are so that we can bring services to them. Some folks, it's super difficult to just walk through the doors of an office and get the care that they need. So we have to bring that to them. And we try to offer opportunities for people to improve their health and well-being. And their health and well-being, to me, could be as much as I started using clean water today to use my IV drugs instead of toilet water. And that's a huge change. That's a huge, beautiful, positive change that folks get to make when they are given the services that they need. Next slide, please. So harm reduction is a whole bunch of strategies. I won't go through all of these strategies with us because I could definitely spend an hour talking about each of them. But, it's things as simple as access to no-cost naloxone so that folks who are using illicit opioids are able to reverse overdoses for their friends and family. And it can be as complicated as a safe supply and creating a worldwide safe supply of substances for people. And in between can be things like drug checking strips, syringe service programs, healthcare coverage, housing first models, all those things help people reduce mortality. So these strategies directly impact people's lives and their long-term recovery. Next slide, please. So I always love to refer to SAMHSA's working definition of recovery. SAMHSA is the Substance Abuse and Mental Health Service Administration. And their working definition of recovery defines a process of change through which individuals improve their health and wellness and live a self-directed life and strive to reach their full potential. I think it's very important to note here that this doesn't say anything about complete stop of use, complete abstinence, moving into recovery. This is for the participant, the client, the patient to decide. They get to decide when they are stepping into health and wellness. And like I said earlier, if you're making that switch from injecting toilet or puddle water to clean water, that's one step forward in that self-directed life to reach your full potential, to heal your veins. It's really those baby steps that make huge changes for folks. Next step, please. So we offer services around the state. There are plenty of other SSPs that we help to support and fund, but the ones that we run directly with our staff are the Queen City Exchange in Manchester. We also have a side initiative to that called Knock for Narcan, where we give out just naloxone to folks on the street up and down Elm in Manchester. The Concord Exchange, the Concord Exchange, which is of course in Concord, and then Hand Up Health Services, which is in the Tri-City area. And we have exchanges in Somersworth, Rochester, and Dover. The exchanges happen throughout the week, Monday through Friday, at different dates and times. They're associated with the best times that we can reach folks and when they can get to us to get supplies. We also have other services that we offer, of course, education and training. That's what I do. We work very hard on advocacy, so we work with our legislators on policy to move forward helpful drug legislation. Right now, we are actually working with Representative Jody Newell on a new drug checking initiative that we really hope passes because New Hampshire is ready to get that technology and use it for what participants really need to know is in their supply so that they can proceed with caution and that they have a better idea of what is going into their bodies. And then, of course, because we are the statewide coalition, anything and all things harm reduction, sexual health related, HIV, Hep C, all these things encompass harm reduction. And we're really able to kind of pivot and do whatever it is to be flexible in those services. So now we're going to take a look at some of the actual data in New Hampshire. So what are we seeing come out of our SSPs? Next slide, please. So Queen City Exchange, which is our biggest weekly exchange. They operate Tuesdays and Thursdays for about 2 hours. Dan had mentioned he had been out there with me every Sunday when we used to operate for 2 hours on Sundays, and we have been out there in every single weather condition watching boxes fly across the parking lot in the million mile-an-hour winds and everything in between. But now we're very lucky. We have a beautiful overdose prevention van, which we'll check out in a minute. And so we're able to offer services directly out of that van. So in the city of Manchester for 2024, we were able to dispose of 428,000 syringes. We were able to distribute 10,000 drug checking strips. So those are things like fentanyl test strips, xylazine test strips. We even have benzodiazepine test strips. So these are they're almost like a pregnancy test if you've never seen one before, but they tell you yes or no, there's the presence of fentanyl, xylazine, or benzodiazepines in your supply, and that way you have a better idea of what you're getting and what reactions might happen out of the supply that you have. For example, if you are a stimulant-only user, it's really important for you to have xylazine and fentanyl test strips so you know if there's going to be the presence of opioids in your supply, so that you can proceed with caution from there. A lot of folks that are just stimulant users are sometimes very novice in their opioid use, so they have a little bit higher risk of overdose because they don't have that tolerance that constant opioid users might have. And of course, the biggest one for me is we distributed 938 doses of naloxone across our Knock for Narcan initiative, which is naloxone that's getting into the hands of family members. It's getting into the hands of business owners across Elm Street. Everyday folks are able to access this, and they're able to keep it on them. And of course, they learn how to use it when they speak to our care coordinator in Manchester. They're able to give folks a second chance, a third chance in case there is ever an overdose that happens in front of them. Next slide, please. Our Concord exchange is our smaller exchange. We run from the hours of 9:30 to 12 in the Concord area out of our overdose prevention van. And while the Concord community is a little bit smaller, we've seen huge impacts throughout the past 2 years. I can remember when we first started the Concord Exchange, Dan and I would sit in a parking lot for 2 hours every night and hope and pray that at least one person would come and get services from us. And since then, it has really blown up. So it's really awesome to see. In 2024, the Concord Exchange was able to dispose of 75,000 syringes. We were able to distribute 2,000 wound care kits. So these are an additional kit that we give out at the SSPs. And if anybody's interested, I can go through every kit we give out. Oh, I see a hand. Hello.
Yeah, I
Go ahead.
just want to know, is that something that you guys give away to like, I work at Archways in Franklin, and we were just wondering about wound care kits because we never get any, and we got some from the doorway, but I'm just curious if that's something that you guys give out to organizations. Sorry to interrupt, but.
No, that's okay. I love questions. So we don't give them out to organizations because they're usually just for that participant exchange. But if Archways in Franklin is looking for the supply, we can definitely chat about having the van drop off some like harm reduction kits, which would have a couple things. So if you'd like, definitely reach out to me after and we can chat about some options.
Thank you. I just saw a message from Corey Gately too. So thank you. Thank you guys.
Yeah, and I am not keeping the best eye on the chat, but so feel free to interrupt me, raise a hand.
Yeah,
I'm
I
totally
have
up
some.
for it, but cool. So those wound care kits have gauze, they have white petroleum in them, they have Band-Aids, they have everything somebody who's especially living outside would need to keep their wounds clean. And then my favorite number for the Concord Exchange is because it's a little bit smaller of a model, the Concord Exchange is really able to access what we call secondary exchanges. So 665 secondary exchanges means that 665 folks are coming to us throughout the year, and they're able to get a couple more supplies so that they can go into their communities and hand that out directly to their friends, family, people who are using. So these are those secondary exchanges where they're really able to become another resource for folks in their community. And people really rely on that. It becomes a really beautiful network of participants really giving and taking from each other and really building that connection, which I also love to see because that just builds their longevity and safety among their numbers. Next slide, please. And then, of course, our oldest exchange, Hand Up Health Services, which has been running since the syringe law was passed in New Hampshire in 2017. For the year 2024, they disposed of 138,000 syringes. They gave out 1,000 sexual barriers, so those are internal and external condoms. And they had about 156 pop-up exchanges. Throughout the whole year, they're popping up across the Tri-City area and getting supplies out to folks who need them. And we just launched our new Seacoast van. So now we are lucky enough to have 2 mobile vans. And I think I am a bigger fan of the new van because it has a beautiful ocean scene on it. Our marketing director is just so talented, and I love to see what they come up with. And And next slide, and we can check out our beautiful vans. So what you can see, our first van here, our overdose prevention van that you may or may not see around Manchester, the Concord area. We had named her Carrie after our original board chair, Dr. Carrie Nolte. And she is big and beefy, and we can fit so many supplies in there. We are so excited to get her. And our second van, which we don't have a name for yet, is a little bit smaller. But the cool thing about this second van is it's really able to get into the smaller places where maybe folks need to be met outside of camp or outside somewhere that might need to be a little bit more discreet, those kinds of places. So if you're in the Tri-City area, keep an eye out for our second van. And let us know if you think of a wonderful name, because we'd love suggestions. Next slide, please. So that is what's new with New Hampshire Harm, but I thought it would be interesting to kind of chat about what's new in harm reduction and what are harm reductionists across the nation and the world talking about. So something that's been really important for me to focus on this last year has been the Compassionate Overdose Response Summit. So this was a convening of harm reductionists across the United States, where they decided to come together and really get down into the nitty-gritty of what is changing in the naloxone markets. What is it that folks really need for an accurate dose of naloxone? And what are some of the consequences when people are given too much naloxone? And the conclusion that they came to essentially is that they had changed recommendations for the time period between giving a first dose of intranasal naloxone that we're all pretty familiar with, Narcan. That's a 4 milligram dose. And beforehand, there had been recommendations to wait about 2 minutes in between doses. But what they found is that because the supply is changing and because there are things like tranquilizers, which do not respond to naloxone, that there may need to be a bigger focus on giving people rescue breathing and making sure they have oxygen than making sure that they have more naloxone in their system. So that recommendation changed from that 2 minutes to 5 minutes. When I'm teaching overdose prevention, I really, really focus in on waiting that 5 minutes. And in the case of an emergency, in the case of a overdose, it is very scary. But remembering the most important part is getting oxygen into that person. And of course, there are all bunch of different brands of higher dose naloxone and different forms of opioid agonists that antagonists, excuse me, that people who use drugs are finding incredibly harmful and not helpful. When you are given naloxone and you are somebody with a very high opioid tolerance, you are instantly put into precipitated withdrawal. That precipitated withdrawal, as some folks have described to me, is more painful than any other kind of withdrawal they've been through. Between waiting for their Suboxone or sitting in rehab, they would rather use, and unfortunately, many of them tell me that they would rather use alone and die than go through that precipitated withdrawal pain again. So we're going to talk about the new drugs on the market in the next slide, but I just want to quickly mention drug checking programs across New Hampshire and drug checking programs across the nation are a huge push this year for harm reductionists. In New Hampshire, we are trying to legalize drug checking equipment. So this means that somebody would be able to bring in samples of what they are using and get a full readout of everything that is in their supply. Depending on the technology, it could be within like a 5% limitation. But for folks in New Hampshire who are so very disconnected and blind to what is in their supply because we have no drug checking technology, this could be huge. Folks who are looking for answers to why their wounds are the way they are. People are looking for answers as to why they're having reactions to supplies from the same people they've always gotten them from, and why they're having severe overdoses or fatal overdoses, or just having reactions that they are not used to. Across the entire nation, there are lots of amazing programs that are running drug checking. They take mail-in samples, they take samples in-house. In British Columbia, they probably have the best model where you're able to walk right in, get your stuff tested, and then you're able to sit down with a peer and talk about like, hey, you don't really use opioids, but there are some nitazines, there's carfentanil, there's fluorafentanil in your supply. So all these different things are being found. How do you want to proceed in this, especially if this is a drug that you were given and you were told it was something like crack cocaine? So a lot of the time is when we're talking to folks in New Hampshire, we have to kind of use our best judgment and say, like, well, if you're using a stimulant, it's not supposed to make you sleepy. So there could be something else in it. We're able to give them fentanyl test strips. We're able to give them xylazine test strips and benzodiazepine test strips. But other than that, we have no 100% confirmation on what is in the supply. And then, of course, we're going to talk about high-dose naloxone. So next slide, and we'll get into that. So there are a couple new forms of naloxone and something called nalmefene hitting the market. Narcan is our typical dose of what we give out at every exchange. We also give out intramuscular naloxone, which we find for folks who are consistent opioid users, they really prefer that IM naloxone because it really reduces those feelings of precipitated withdrawal. It's a 0.2 milligram dose. So it is simply giving you the ability to breathe back and not ripping off every single opioid from your receptor. So you might still, we've had reports of folks telling us that they're able to wake up still a little high and still feeling the way they wanted to feel, but they're able to wake up and then have somebody watch them. They're able to proceed with more caution. And to me, the most important thing is they're going to stay around their friends and loved ones who gave them that naloxone in the first place. So if they go out again, they're able to stay safe. What we're finding is when folks are given things like Cloxato, which is an 8 milligram naloxone, and unfortunately, Cloxato kind of came on the market from some very heavy fear-mongering. There was a lot of misinterpretation of what some groups thought was a naloxone-resistant opioid, and that's not true. There hasn't been a naloxone-resistant opioid been found. And so they believed, oh, well, we need many, many more doses of naloxone to be able to bring people back. But what's really important to note is that Cloxato has that 2 to 3 hour half-life. So folks are really stuck in that precipitated withdrawal for 2 to 3 hours. And that pain is really hard to go through. For me, I think the biggest offender here is Opvee. That is not naloxone, it's nalmefene. And folks who are given this have a half-life of 11 hours. So for 11 hours, you are put into precipitated withdrawal. And no matter the amount you try to use again, it sticks there and you are in that horrific pain that folks are so terrified of. I think it's really important to note that folks who use drugs, when they are just trying to get into recovery, what is the biggest thing we hear from them? That I don't want to withdraw. I don't want to be sick. So if that is such a barrier to getting healthcare and the help that some may need, then if we are doing that to folks who just experienced a traumatic event, because an overdose is a traumatic event, they are going to recede from care and recede from professionals and feel even a bigger lack of trust than they already have, for EMTs, for law enforcement, for peers. And that's exactly what we're trying to move away from. We want to make people trust us more. We want to make sure that they feel loved more, because those things are evidence-based. What folks in the harm reduction world really want to make the standard of intranasal naloxone is something called Revive. It's a 3 milligram dose, so it's like 1 milligram lower than Narcan. But it seems to be the kind of perfect sweet spot for folks who are using intranasal naloxone. You know, we totally understand that IM naloxone for somebody, like especially a family member, that can be scary to give someone. But that intranasal really gives access to everybody being able to reverse an overdose. So there are lots of different options, and I implore you, if you are someone who purchases naloxone for your company, for your hospital, for anything, really take a look at where your supply pushes are coming from, who is giving you deals, and what do the people who are using drugs really want? They want to feel safe. They want to feel not sick. And that compassionate overdose response is prevention for further overdose. Next slide, please. So, just to kind of touch on some quick drug trends around the nation and around New Hampshire, you know, I will say for the state of New Hampshire, everything I'm saying here is allegedly and anecdotally. We have a pretty solid idea of what's going around. I'm connected to a lot of drug user groups and drug checking groups around New England. So a lot of the times when you're able to kind of go around the state, you can get an idea of what's coming in and out. But again, we have no way to confirm this. We absolutely need drug checking services to be able to confirm that this is what's being found in our supplies. But we can say that from participants' reports of using xylazine test strips, that they absolutely have supplies of fentanyl that have xylazine in it. They're finding fentanyl in stimulants. There has been a big resurgence of crack cocaine or rock cocaine. And in that, folks are finding fentanyl cuts, they're finding xylazine cuts, and they're also finding nitazine cuts. There hasn't been a whole lot of like lab confirmed nitazine tests yet. So again, we can't 100% confirm that, but we have a fairly good idea of what is going around. Now, if we're talking about nationwide, especially in places that have legal drug checking services and really robust programs, I always look to the University of North Carolina, Chapel Hill. They have an amazing program called the Opioid Data Lab, where they really focus on what is going around. And they put it into a language that anybody and everyone can understand, which I love. So in the summer of 2024, there was a mystery substance that was going around everywhere. You know, I can't confirm in the state, but from anecdotally of what I heard from participants, we probably had a little bit of it here too. It was causing folks to kind of cough up blood, have really heavy respiratory issues. Folks were getting pneumonia very easily in the summer, and people were feeling sick and just not feeling like themselves. And essentially what they found was, it's called BTMPS. It has a really, really long scientific name that I will not try and embarrass myself reading, but essentially this chemical is an industrial chemical. It's usually found in like Febreze, and it's commonly used as like a plastic protectant for like ultraviolet rays. But it was being cut into fentanyl, it was being cut into xylazine, and it was causing a lot of throat irritation, and it was causing a lot of pain at injection sites and poor wound healing. What some of us might know is that xylazine has caused a lot of poor wound healing and a lot of intense wounds for people. So sometimes people would think that it's just a xylazine wound, because what happens is no matter injection or smoking or snorting, if you're using xylazine, you can still get the same wound. And they are very, it's very easy to tell when it's a xylazine wound. They have a very specific look to them. They have a very specific healing pattern, and they take folks a while to heal from. But that kind of industrial chemical kind of passed through the US pretty quick. We're not finding it as much right now, but it was definitely something that impacted folks for a good chunk there, and they definitely saw some venous damage. Nationwide, and in New Hampshire, there has definitely been an uptick in benzodiazepines in the opioid supply. To me, I believe this is super important to focus on, because as we have an unregulated supply, and unfortunately we live in a polysubstance world, it makes getting into detox so much more difficult for folks. Somebody who's ready to enter into treatment tomorrow, if they pop for benzos, what happens? They get sent to detox, and there's no detox beds for them to go to. And they could have never known that they were using benzos, because sometimes it creates the feeling of what they thought fentanyl was or what they thought heroin was. So having that in the polysubstance system of supply really impacts folks' ability to get into recovery. To me, that is why drug checking services is so important. So I can know what's in my bag before I use it, especially if I'm trying to go to treatment the next day. And then, of course, there has recently been a rise in nitazines. So nitazines were originally developed in the 1950s by like a Swiss chemical company. They were like a new kind of painkiller, and they were found to be too potent to ever be a medicine, because they did believe that in small doses they could cause an overdose. But now here we are decades later, and those nitazines seem to be popping up again in the underground drug market. They're being sold through a lot of advertisements on websites and apps called Telegram. Telegram is a really unregulated communication app. It's an app that like some fringe groups use, like various neo-Nazi groups use it to communicate among each other, because it's a very fringe app. And on that, you can, purchase your unregulated drug supply. And because nitazines are just now coming into market, there hasn't been a push from really any law enforcement groups to really get that under wraps and see what's going on there. And unfortunately, the thing with nitazines that's happening is they are just one more potency cut into the supply. The same exact thing happened in 2017, where we saw the huge uptick of fentanyl. When the opioid epidemic started, we moved out of that prescription painkiller. Folks were getting heroin when heroin was not potent enough, and they made it harder to get. Folks had to get something more potent so they could make more of a supply. So that's why fentanyl came onto market. You're able to use less fentanyl in more baggies, and you're able to get more out. Nitazine is kind of doing the same thing right now. I can't say that we've found it in New Hampshire. There has been something potent going around the past couple weeks that people have definitely been passing away from. But it is what happens in prohibition. You remove things from market, you put harder restrictions on things, something more potent pops up, and then we continue this cycle forever. So I think that's really important to remember, that it is just so hard to exactly nail down what we have in this polysubstance world. But like one final reminder is that among the nationwide drug checking programs and the experts who are way smarter than I am, they are not finding naloxone resistant opioids. all these opioids react the same way to naloxone. They might need a little bit more or a little bit less, but what they really need is oxygen. They need that rescue breathing for folks. Next slide, please. So, now that we kind of went through all that, hopefully I have given you a little taste of what you can expect in a training with me. But I offer really any topic of training that folks are looking for. Here are just some examples of some of the trainings I've presented in the past and some I hope to do in the future. So overdose response and prevention, that's a simple one. What is an overdose? How does it happen? How do you administer naloxone? We have separate trainings for naloxone administration for intranasal naloxone and intramuscular naloxone. Harm reduction 101s, which I love for folks who, to me, it's really important for like front office staff, people who are answering phones in medical departments, anything like that. When you're coming in contact with a patient, that is where their stigma will start. The first face that they see, if they are stigmatized by it, if that person who is serving them doesn't understand what they're going through, then they will stop care. So harm reduction 101s are really just the go through and the basics. Starting up a syringe service program. Part of my job is technical assistance, so I'm able to really help anyone and everyone who wants to start an SSP from the ground to your first day. And I'm able to offer that in-person technical assistance where I can sit by you and say, like, these are the best practices. I have started an SSP by myself and run one too. So hopefully I have some of the experience that we can work together. And then drug checking 101, what is it? The nitty gritty of that. Drugs 101. I find that folks really love the drugs 101 because we talk about all the different varieties of substances and what are their actual effects and what are their long-term effects, what happens when things are combined, when drugs mix, what kind of feelings do you get out of that? So we go into those kind of details, and then in that, of course, we talk about like safer use practices, the basics of if someone is going to set up a crack stem for the first time, how do you do that and how do you do it safely? So we go through all of that. And then, of course, enhancing provider skills. It's an expert video training. So we have 3 nurses who talk about their personal journey into harm reduction and the evidence that they work with every single day. And we'll actually hopefully be hosting that soon with North Country Health Consortium. They'll be putting together a Moodle presentation with that video, and we will be hopefully distributing that, I believe, in March. But keep your eyes and ears open for that because that'll be a really amazing training. And then, of course, harm reduction outreach practices. So this is based off of my lived experience and my experience in working directly in encampments, on the street with folks, and like, how do you just use harm reduction in your outreach practices when you're talking to people, when you are trying to give services? And going over all the basics of, these are people's homes, even if it doesn't look like it. So don't shake their tent and open the zipper, basics like that. But it's amazing how easily it is to skip the basics. And then, of course, I am always up for any kind of custom trainings tailored to your program. I also love doing any kind of like basic education about HIV and Hep C prevention, testing, all those things. Those are big passion projects for me. And of course, anything relating to LGBTQ plus rights and how LGBTQ plus lives intersect with people who use drugs and healthcare systems. Next slide, please. And then finally, here are all of our 12 operational SSPs across the state. These are all the registered programs. You know, I can't speak for the rogues out there that are getting stuff out, but they're definitely out there. My hope for 2025 is that we can get one more SSP in that top of the state because it's pretty empty out there. So I would love to see another SSP pop up there so that folks can really get to services. And next slide, and that is that. So I open myself up to any questions, comments, concerns. I would be so happy to talk through anything. And oh, I see a hand. Go ahead.
Hi, can you hear me okay?
Yeah.
Great. So my name is Karina. I'm a person with lived experience. I'm also a master's in public health student right now. So I have a question. It might be purely academic. So I've been doing some research about people who inject drugs in New York City, and there was a paper that came out that said about 56% of people who were surveyed prefer to use alone. So other than like continuing to build trust through compassionate outreach, is there any specific programming that you know of that aims to target people who prefer to use alone?
That's a really good question. So I think that like simple things like the Never Use Alone hotline is always a good reference that we'll give to people that like using alone. Um, but we do try very hard to like have people nail down their safe people when we're working with individuals. And it's really amazing to find that once you start going through the list with people, they do have at least one safe person they can be with. And I think the other thing is that, especially in New York, I know that they really push for OPCs, overdose prevention centers, because at least there they're able to build more community. They're able to, you know, make that connection to meds and everything else. And I think that's the other thing that we try to focus with people is, you know, go to the places where you feel like you're in community. A lot of the time when queer and non-binary folks come to us, you know, there's lots of different resources that we can give them that so they'll be in their community. And it might sound silly, but the other thing that I usually tell folks is that do you really like a hobby? Because I guarantee you that there will be drug users in that hobby. Do you like playing pool? Do you like knitting? Building those communities yourself. And sometimes we do have to start from the ground up in building those communities. Another program is any kind of the virtual Harm Reduction Works meetings. Harm Reduction Works is completely like decentralized and, you know, at New Hampshire Harm, we try to run one at 12 on Thursdays. We've had low attendance, so they haven't been super popular. But I know that like in Massachusetts, Jess Tilley at H2RC runs a bunch of different programs for parents, for teens, for loved ones of people who use substances. So like finding those pockets. And then, of course, any kind of drug users union. Those unions are really great connections for folks, and that's just one more network for people to stay safe.
Thank you. That was a good answer.
You're welcome. Any other questions?
I'm not seeing any more questions pop up. Oh, there's Karina has raised her hand again.
I suppose if there's no other questions, I'll ask my second one. So let's see. Obviously, we're living in this very interesting political climate where the OPCs in New York City are at risk of like getting shut down and stuff like that. How do you, as a person working in harm reduction, sort of do PR for harm reduction? Like, how do you sort of speak to people who are not into the idea of alleviating negative consequences for drug users because they believe drug users should have negative consequences and they believe it's a deterrent to drug use or poor behavioral choices? How do you sort of like emphasize that harm reduction is a community-wide practice?
Um, I used to really focus on like the venom of it because it makes me so angry. So I'm still trying to figure it out. But I will say that I think a really helpful thing is my perspective definitely changed when I became a parent. And I think I was able to speak to folks a little differently in that kind of like parenthood role because so many people who have that association are thinking, oh, well, what if my kid gets stuck at the park or something like that? And the other thing is, bringing it back to the cost saving benefits of harm reduction. If you don't want needles in the park, then have safe disposal. Participants are safe-led. If you don't want to see people high on the streets, give them more shelters. And it's so simplistic in like that automatic thinking, we would hope, but reframing it of like a person with HIV who's uninsured is like a lifetime of care is like $500,000. So by giving them a 2-cent syringe, we're reducing that cost for everybody. So a lot of the time I do refer back to like the money behind it, which feels gross sometimes, but the money
Not
behind
at
it,
all. It
yeah.
works.
The money behind it seems to really gets people's wheels rolling with it. And also just saying like if you don't want people to see what you're afraid to see, then give them the services they need to be inside. And a lot of the time that's OPCs. That's safe use places. It's a tough pill to swallow, and I get it, but I think just always reframing it back to the evidence. Like we have so much positive evidence that we can and will go blue in the face repeating the evidence back all day. Hopefully that answered your question.
Yeah, thank you so much. Really liked your presentation.
Oh, thank you.
Anyone else? I just want to point out that Peter Fifield has placed a very interesting article in the chat on why facts don't change people's minds. As Liz has said, the evidence behind harm reduction is so overwhelmingly compelling that somebody who, like me, has spent a career in safety and public health is just amazed that there isn't more support for this. But the more we understand about our cognitive processes, the better equipped we are to find new ways to communicate information. Liz, thank you so much. That was just an extraordinarily full, rich, and well-presented time with us today. And thank you so very much. I should have mentioned too, I didn't even introduce myself because I was excited to get to Liz's presentation here and forgot to, but I'm Dan from the Foundation for Healthy Communities. And in full disclosure, I also serve as a volunteer and as the treasurer of the board for the Harm Reduction Coalition, and am delighted to be a part of that organization's work in whatever modest ways I can. And have been so impressed watching literally hundreds of people being served by this and knowing that they, some of them are alive today simply because this is the case. I was a paramedic for a long time, been to a lot of these overdose death calls. Nobody died who was with other people. Everybody who died alone. So that's a huge thing. And thank you, Karen, for raising that. So if there are no further questions, I'm going to close us out a little bit. And I think that Danny has probably got his finger on the button for a few more slides as we close the meeting. The resources for today's meeting, the video of this, and many others can be found at the New Hampshire Technical Assistance Center at nhtac.org. I type that into my computer about 3 or 4 times a week. So it's a great place, not only for presentations like this, but across the range of community practice events. And Growth Partners has resourced that website with an incredible diverse variety of resources speaking to a number of areas in the public health and really leveraging their incredible expertise in this area across several states. Our next meeting is going to be on the 4th Thursday of the month. That's April 24th. We are moving that because the Recovery, Inclusion, Community, and Harm Reduction Conference is on April 16th and 17th. We hope to see many of you there. I'll be both attending and tabling at that event with our healthcare navigators. So that's an exciting thing too. At that meeting, we're going to have Dr. Jason Lucy present. And those who know Jason know that he is also part of this harm reduction work and one of the great voices in the state, and brings a tremendous amount of clinical experience and expertise into this. And then in June, we have Jennifer Chisholm, who used to work with the Healthcare for the Homeless team out of Catholic Medical Center and is now the executive director of the New Hampshire Coalition to End Homelessness. Jennifer will be presenting on the intersection between homelessness and substance use. And it's going to be great. We had coffee and we talked for like an hour and a half, and it's going to be a great presentation. You're also welcome on that website to join this community practice if you are not already, or other communities of practice. And I believe that Danny is probably teeing up the evaluation link, which we'll leave up there. If you want to just click on that, I believe that you can complete that even if we are closed in this meeting. Danny, did I forget anything?
You got it all, Dan. Thank you very much.
Okay, no further questions. Wishing everyone the rest of a good winter, and know that when we meet again, we will be solidly into the spring. And thank you so much for attending today.